Good afternoon. My name is Pang. I'm the duty doctor on Harvard Ward. I have to apologize for not being able to give this talk in person because of the change in ward round days. But if you have any questions regarding this session, please feel free to drop me an email or stop me in the corridor and I will try my best to answer you. So let's jump into the topic for today. Let's talk about anaphylaxis and its management. So what is anaphylaxis? It is a serious allergic reaction that has a rapid onset that can cause death. It has been found to affect 2% of the population, and this may increase in the future due to the clean hygiene hypothesis. Just for interest's sake, what is the hygiene hypothesis? At a young age, when we are just born, we need to be exposed to various allergens to train our immune system to recognize what is true threat to the body and what is benign. However, when you're born into an average family in the UK, where your surrounding is clean and you do not have any other siblings around you to have cross-infections with, your immune system is undertrained and therefore would not have the ability to recognize true danger. As such, this makes your immune system to have the ability to overreact to foreign bodies, which can cause an allergic reaction. Anaphylactic reactions is known to happen in hospitals, but it is often unrecognized, untreated. So if more people are aware of it, the better the chances we are at detecting and managing them appropriately. So, what causes anaphylaxis? A variety of things that are listed here, but the three things that are commonly seen in hospital settings are food, medication, and occupation. The actual medication itself is normally not anaphylactic, but it is the solvent that comes with it, which sometimes could be made from oil-based materials like nuts or from eggs. You can see the IgE stated on the slide here. It stands for immunoglobulin E. It is a class of antibodies that causes allergic reactions, including asthma. I will return to this IgE in a later slide. Just for interest to know, IgG, which is immunoglobulin G, is the one that our body uses to fight infections with. So how does anaphylaxis occur? Here is a simplified diagram of how anaphylaxis occurs. So let's start from the top. When a person for the first time comes into contact with an allergen such as penicillin, immune cells, here I've labeled APC, which stands for antigen presenting cells, takes up the penicillin, smashes it up into pieces, presents it to the T cell. This T cell will then process it and activate. So, in anaphylaxis, the problem arises in what the T cell activates. If the T cell activates an IgG antibodies, it can help clear infections. If the T cell activates IgEs, you will be getting an allergic reaction. This IgE then coats a cell called the mast cell, which can release histamine that is already pre-made within itself. The release of histamine will then cause blood vessels to leak, which can result in swelling, or in medical terms, edema. This edema or swelling can cause the following signs and symptoms, such as breathing problems, abdominal problems, skin problems, and problems within your vessels. So, here are a list of signs and symptoms that can occur with anaphylaxis. We also in this slide talk about how frequently they occur. The most common sign are skin signs. Here, skin can get red, can swell up, can have itch. The same swelling can occur in your lungs, which is dangerous if your lungs, upper airways swell up. It can block you from breathing, causing a choking sensation and stridors. The same swelling can occur within your GI tract as you absorb the drug or allergen. This can cause you to vomit as your GI tract cannot absorb fluids and food. Cramps within your intestinal muscles are also common, which contract due to the inflammation and swelling it experiences. The last and final thing it can do is to cause you to lose your blood pressure by overtly expanding your vessel diameter. When this happens, your body collapses, the patient faints, and your heart tries to pump harder and faster to cope with the expanding vessel size. Therefore, you will get a high heart rate. If left for too long and not treated, you can get end organ damage, which is damage to your brains, kidneys, and heart. So, this slide is the same slide that you have seen earlier, but I would like to point out something many people, even doctors, tend to forget. When you have an anaphylactic reaction and when you recover, be sure to keep an eye for a delayed secondary anaphylactic reaction. Let me explain to you how this happens. Remember the mast cell that we talked about earlier, and that it has the ability to release histamine? Upon releasing all the histamine it has, it also has the ability to make new histamine. Since it takes time for it to make new histamine, a secondary reaction, a delayed anaphylactic reaction, can also occur. And if we are not aware of this and we leave the patient to their own accord after their first initial attack, we can potentially miss this life-threatening secondary reaction. So, biphasic anaphylaxis. Biphasic, on the title of the slide, states there are two reactions which I've mentioned just now. The first, that arrives within minutes to the first hour. The second, which is when the mast cell will make more histamine to cause a secondary reaction. The text in the red is the definition, which is the recurrence of symptoms that develop following the apparent resolution of the initial anaphylactic reaction with no additional exposure to the allergen. This occurs in 4.5 to 23% of all anaphylactic reactions and can happen between 8 to 10 hours after the first attack. However, there have been reports that it can occur up to 2 to 3 days after the first reaction. The last point on this slide is for completeness sake. Protracted anaphylaxis is basically an anaphylactic reaction that has lasted for a long period of time. This is very rare and normally will be dealt with people in ITU. So, what to do when I suspect someone with anaphylaxis? The first thing to do is ask for help as fast, as soon as possible. But while waiting for help, while waiting for the duty doctor or the ambulance to arrive, there are a few things you can do to confirm and help manage anaphylaxis. Unfortunately, the best way to confirm whether a patient has an anaphylactic reaction is to see patients having an anaphylactic reaction yourself. However, barring from that, we need to look for anaphylaxis systematically. We doctors use an ABCDE approach to detect a variety of different things in a patient, and this also includes anaphylaxis. So starting from A, we look for swelling at the lips, listen for their breath sounds. We listen whether we could hear them panting, whether we could hear them wheezing, and whether all these sounds can be heard without a stethoscope. B is for breathing. We do stats here for the patient. We use a stethoscope to look for wheeze. Next is to count the respiratory rate, which is a very good measurement to figure out whether a patient is improving or getting worse. At this stage, if you find the sats low and the patient is gasping for air, give as much oxygen as you can. Turn the oxygen dial up to max. People will say, when I say people, I mean other doctors might comment that patients with COPD, that is chronic obstructive pulmonary disease, a disease that occurs in people who smoke for long periods of time, in people with COPD, you should not be doing this. You should not be giving them high amounts of oxygen because they can retain carbon dioxide by stopping to breathe, by stop breathing. But high flow oxygen for retaining COPD patient for a short period of time does no harm. And if need to, the duty doctor can come and reduce your oxygen. On top of this, the proportion of patients with COPD who are retainers are actually very small. We're talking about 1 to 2% here. C is circulation. Here you do all the usual BP, heart rate, and capillary refill time. In anaphylaxis, we expect a patient to have a low BP, a high heart rate to compensate for the low BP, and a capillary refill time that is longer than 2 seconds. So what is this capillary refill time? The capillary refill time is the time it takes for blood to return back into the capillaries. So, how to test this? To test this, you basically press onto the patient's nail bed for 5 seconds and then release it and count how long it takes for the pinkness in the nail bed to return. If it takes more than 2 seconds, this patient is probably underfilled, is probably dehydrated, is probably having an anaphylactic reaction, is probably bleeding. So there are a variety of reasons for it. But it's a good sign to find in anaphylaxis also. Since we cannot give IV fluids in Glenborn, the one thing we can do is to lie the patient flat so that enough blood is reaching the brain, and also to raise the patient's legs to about 45 degrees or more. By doing this, by raising a leg, what you have done is basically you have given the patient a 500 ml extra blood for the heart to pump with. This technique has been not used by a lot of doctors, but it's actually quite a useful test as well, something to help with the patient's symptom. D stands for the disability. Here is where you do other stuffs like BM, your blood sugars, your temperature. It is important to remember that hypoglycemia can mimic signs of anaphylaxis, and it's important to tease them out. The AVPU on this slide stands for alert, voice, pain, or unconsciousness. It is a scale we use to rate how conscious the patient is. It is quite often used by nurses to give information to doctors regarding the conscious state of a patient. This scale is quite self-explanatory. So if you shout at a patient and he's not responding, what you can do is you can try and squeeze the trapezius, squeeze the shoulder, which what we call in the medical world as the trapezius squeeze. If they respond to that, that means they are P, they respond to pain on the AVPU scale, AVPU scale, and if they do not, they will be defined as being unconscious. The final point here is E, which is exposure, where you look at the skin signs that we have mentioned before. One last thing to remember, that you don't need to go from A to E one by one. You can do all of them simultaneously if you have more nurses around. The A to E is something to help you to remember only. So this is a picture I got from Google, which shows how a person does a trapezius squeeze. So you can try squeezing yourself to see how painful it is if you do it properly. So what the doctor would do upon arriving to review this patient, he would first do the ABCD again quickly, confirm that it is anaphylaxis that we are dealing with. Since here at Glenborn we are not equipped to deal with this, he will most likely call the ambulance to transfer the patient over to Derriford. He will then, in the meantime, get the adrenaline injection from the crash trolley and inject the patient with 0.5 mils of 1 in 1000 adrenaline intramuscularly (IM). He might do this a couple of times. Probably every 5 minutes. And just for your information, that there is another 1 in 10,000 adrenaline, which is also inside the crash trolley, which is used for cardiac arrest and should not be used for anaphylaxis. Other stuff that he might consider are like chloramphetamine, which is an antihistamine to fight the histamine released by the mast cells. Hydrocortisone, which is a steroid to manage the generalized inflammatory reaction of the body. Before I forget, the adrenaline is to help Its function is to help clamp down on vessels so that they stop leaking, and also to help the blood pressure to increase back to normal by making the smooth muscles around vessels contract. After giving adrenaline, the patient will sometimes say that he or she can feel her heart racing. This is quite normal. Um, so here are some of the pitfalls a lot of us, including the most experienced of us, make. Number one, waiting for the BP, the blood pressure, to drop before reacting. If a patient has skin and chest signs, we need to get on and manage it. Number two, sometimes patients are on antihistamines for various reasons, like hay fever. They use it to suppress coughs if they're chronic smokers, vertigo or nausea, and for sedation purposes, which, for example, quite commonly we use it on our wards. Promethazine is a very common antihistamine which is used as a night sedation. By using these antihistamine, this would make patients who have an anaphylactic reaction ongoing have no skin signs at all. Third and finally, if a patient tells you that he is asthmatic and you can see that he's struggling with his breathing and also has some skin signs, redness, swelling, itches on his skin, rather than having this patient, diagnosing it as an asthmatic attack and giving salbutamol inhalers, think of anaphylaxis. So we have come to the final slide. In summary, anaphylaxis can kill. It is often missed even in the most experienced of us. Use the ABCDE assessment method to assess and confirm while waiting for the duty doctor. You can do things, even though they're simple, which are very helpful if you give them early, like oxygen, lying the patient down flat, raising their legs. And also, don't be afraid or shy to say what you think might be the cause, as the doctor, who does not know the patient as well as you, can be quite clueless sometimes. And finally, anaphylaxis is treated with adrenaline, chloramphenemine, and hydrocortisone. Thank you very much for your time, and sorry that I could not be present for this talk. If you have any other questions, feel free to write it down for me on the piece of paper, and I'll try to attend your next session just to give the answers. Also, I would be grateful if you can fill up a feedback form for me to improve my future presentations.